have a panel. I'm actually excited to introduce two of my colleagues from Kennedy Krieger Institute in Baltimore, Maryland, Dr. Cristina Sadowsky and Jennifer Keller, who are going to talk about an important and probably not discussed enough topic, ALD Below the Belt. Thank you.
Hello. So a change of pace away from gray zone and to a topic that comes up in patient discussions all the time. We talk about balance, we talk about gait, we talk about spasticity and pain, and then there are the questions that people are a little more hesitant to discuss. And so for years, I've been saying we should have a discussion about ALD below the belt. Not just your feet and your legs, but let's talk about bowel, bladder, and sexual dysfunction. They are issues that patients report amongst and between ourselves and our physicians, but can be challenging to find expertise. It can be challenging to find guidance, and people are often too hesitant to bring it up even with their own providers. So I thought, let's just have a nice Saturday morning chat about those three hot button topics. So I'm going to allow my panelists to introduce themselves. We have Jennifer Keller and Dr. Cristina Sadowsky. If you want to just give your backgrounds, and then we're going to chat.
Hi, I'm Jen. I'm a physical therapist and an assistant professor at Kennedy Krieger, and I started with research in AMN with Dr. Mosier with the Lorenzo's oil study, so it's been a while. And usually I talk with you about balance and gait, but I've been invited to expand a little bit of my knowledge to you today on this topic, so thank you for having me.
Sorry, I didn't say hello to anybody today, so I'm saying hello to everybody else here. Thank you for having me. I'm Cristina Sadowsky. I'm an associate professor of physical medicine and rehabilitation at Kennedy Krieger and Johns Hopkins. Why do I get to share this time with you is because I, in my capacity as a spinal cord injury medicine specialist, I am very familiar with neurogenic bladders, and I perform neurodynamic studies at Kennedy Krieger, including on individuals that come and seek expertise in the ALD clinic. So that's my claim to fame.
Excellent. Well, thank you both for being here. And I'm going to ask just for everyone in the room, as well as people on Zoom, we will be taking questions, but instead of us putting together a presentation and trying to explain lived experience to people who live it, we thought this would be a wonderful opportunity to get the discussion started, and hopefully I'm asking folks to be brave and to ask your question. As always, you have an opportunity to put it in through Zoom. You can pass a note. We can go full 7th grade on this, but really, we are all together, and I just would love people to really get the clarity you need. So I'm so glad that you both agreed to do this and talk. I know certainly I'm fortunate enough to be part of the symptomatic women's group that meets on Mondays once a month, and it comes up with great frequency, no pun intended, bowel hesitation, bladder hesitation, bladder frequency, leakage, a whole bunch of other topics around neurogenic bladder. And I'm wondering if either of you feel comfortable to describe maybe why or how, what is the fabled neurogenic bladder, and if there's anything that either of you would suggest that people do to accommodate that, or tips and tricks or treatments to get around that.
Okay, I'll start with the reasons. So ALD is a central and peripheral nervous system disorder. So it affects the control of the bowel and bladder through affecting the autonomic nervous system, which is the nervous system that controls everything whenever we're not thinking about controlling breathing, heartbeat, blood pressure, bowel bladder, the spontaneous evacuation. So we have all kinds of changes in individuals with symptomatic individuals with ALD. They can be what we call overactive detrusors, so increased urinary frequency, urge incontinence, needing to go very frequently to the bathroom, and probably having the cold temperature here, plus the hot coffee, the caffeine, probably that triggered a lot of bathroom visits today. So that's one type of bladder problem. And I have to say, bowel and bladder are innervated by the same system, so they kind of go in parallel. It's just that the bowel is a little bit slower because it's a bigger capacity system, so it reacts slower, but it has the same characteristics that the bladder. So we study the bladder and we know what the bowel is going to do. The other pattern that can occur is in the myelopathic condition only. It is what we call a detrusor sphincter dyssynergia, meaning that when the bladder contracts, the sphincter contracts in the same time. Clinically, it manifests the same way. Urgency, needing to go to the bathroom frequently, but the treatment is different. So each of these conditions can be addressed pharmacologically with drugs and with some other interventions that Jen will talk about. And then the third condition is when the nerves are demyelinated. So once they left from the spinal cord and there is demyelination in the peripheral nervous system, in the spinal roots, we have what we call a lower motor neuron, which for you all guys translates into a lazy, high-capacity bladder. So plus inability to void with urinary retention. So individuals with ALD can have any type of neurogenic bladder. The most common is the detrusor sphincter dyssynergia if it is the myelopathic form. If it is the cerebral form, it's going to have the overactive and lack of voluntary control. And if it is lower, the myelopathic with peripheral nerve involvement is going to have a lazy bladder. Bowel is the same. I'm just going to mention that sexual function in males, on top of the fact that we have the same innervation that affects the ability to have erection and ejaculation, so a neurologic cause for dysfunction, there is the adrenocortical insufficiency, which creates a chemical cause for the erectile dysfunction. So we have nerve, we have cabling problems, and chemistry problems. So yes, it is very common. There are few studies that look at it, and they're all clinical and by report, and they say 50%, but I bet you it's a lot more than that. I'm going to let Jen tell you what to do.
Great. So I think probably, I don't know if anyone has even really ever considered this, but we actually have started just in the field of physical therapy to talk about how the pelvic floor is really involved in like one of our core muscles. It's actually really coordinated with our diaphragm and our transverse abdominis muscles. So those are the ones that are on the side of your lower abs that all of American women squeeze in all the time to look thinner. But by squeezing them in all the time, you are actually creating pressure on your abdomen, which then actually, weakens your pelvic floor. It's putting pressure on there, and it makes it much more likely to have leakage or other problems. So it's really a dynamic system. And I think actually our friends in Australia, they can do all sorts of really super cool studies that we don't really do here. And they've done a couple where they've had people have a really full bladder and then stand on a force plate and see what their balance is like. And not surprisingly, when you've seen, our children race off to the bathroom and their legs are held together, they are trying to both prevent voiding and, get where they're going. And so their standing balance is worse. And so they found some really interesting studies that people sway more when they have a full bladder or when they are needing to have to pee. So I think that's a really important thing for us to be considering, that these imbalances that we're seeing in your stability may actually also be, somehow connected to your, continence level. Similarly, they've done studies where they had people have a full bladder and walk as quickly as you can. So after you've voided, or when you have just the beginning feeling that you might have to go, you can walk very quickly and comfortably. But when you have a full bladder, you cannot walk as fast as you need to. So if you come to our lab, we actually usually recommend that you void before you do any of our tests to be sure that, but that's an interesting complicating factor. So I'm kind of throwing this out there because I think everyone's probably heard of Kegels. And they're really important in terms of, you have a weak muscle. It's probably weaker due to AMN. And so you need to be able to activate, your pelvic floor. But that's similar to if anybody's had like a knee surgery or something, just basically doing a quadricep, like, contract your muscle, relax and contract your muscle. But that doesn't really help you in a dynamic way when you then go to use your knee to walk. And that's the same sort of thing. So interestingly, we can use our breathing system to activate our pelvic floor. If you take a breath in, your pelvic floor lengthens. If I had a balloon, you can kind of get a good idea, but it has to make space. Your abdominals have to make space, and your pelvic floor has to make space for your abdominal contents to descend a little bit when you take a breath. And so I have a few tips and tricks other than Kegel. So if it's good, I can give you my three take-home exercises. So one thing, tight hamstrings will make you sit in a rolled back, and that actually lengthens your pelvic floor and makes it hard for it to contract and be active. So now everyone's going to improve their posture and sit up straight, right? Okay. All right. So on top of that, if you want to void, you actually want to lengthen them, let them relax, and that's difficult, right? So you've seen the squatty potty out there. That's ideal for ladies like me who are short, who now have the higher elevated toilets, which are great for helping us get up and down when we have weak muscles, but are now a problem because our feet aren't really on the floor and we don't have a shortened pelvis. So a squatty potty or leaning forward to pee like you think of a guy doing, that will actually also help you eliminate or void. And so that's your second take home. The other one is blow before you go. So you can engage your pelvic floor by blowing out or expiration, but that's not always something that you do like just naturally. So you want to actually, before you say go to stand up, because typically people talk about leaking when you change position, or that can be common. So taking a breath in and then blowing out, and then going to do your movement. And that will actually help you engage your pelvic floor before you stand. I guess I have two more. So the other thing is, you probably don't know that little muscles that stabilize our core actually turn on before we do a movement. So as soon as we tell our arm that we need to reach for something, before you even turn on your shoulder muscle, your trunk muscles turn on to keep you stable. And so similarly, that blow before you go thing, whenever you go to do something, just try and start incorporating that breathing into your regular routine. And then if Jordan, you're still willing to do it for me, you come up, and there's this other one that's called the butt wink. And so it has to go with the fact that you want to keep that good upright posture, that good neutral alignment. And this is super common. I don't know if anyone has seen it, but on the it's CrossFit, they have this YouTube video about how do you pee when you work out? and it's like it's like a mark of how hard you're working. But you really should not pee when you exercise, okay? And so a lot of it has to do with the fault. So Jordan's going to do a squat like he would be doing a deadlift squat as low as he can go, and what you can see is at the end range he starts to get like kind of his tuck under of his bottom and a lot more flexion at his low back. So I would cue him to try and lift your tailbone when you go down, and then as you come back up, maintain that position. And in so doing, that allows the pelvic floor to engage appropriately and not have you have leakage or some other problem when you're moving. And these are things that, so I think I'm even don't talk about, thank you very much, Jordan.
You're a hero.
I don't think we talk about it enough in clinic, so I think it's an important factor. I think also when you go to physical therapy, not all of us are trained to the extent we have training, but we maybe don't incorporate it. So there are pelvic floor experts that that you can add to your regular physical therapy routine to go to. And the American Physical Therapy Association just came out with some clinical practice guidelines, which is what guides our treatment. And one of the things they have brought up is that they're finding better results in conjunction with medication if you also have some physical therapy, input as well at the same time. And so there are other things besides Kegels, but like electrical stimulation and things like that that can also be helpful. And that is not my scope, so you should find a colleague to go on for you for that. But thank you.
This is an amazing start. Thank you both so much. I will ask, because I know this is being typed into a Zoom comment somewhere. Do both of you see patients, and are you, because these are such questions that people have and would love your expertise, are you accepting patients? Can people come see you for this?
Yeah, anytime.
Just thought I'd check. So with that said, these are great tips and these are great things to think about and talk about with our own physicians at home. I guess my question is, what kind of team should you assemble? Who is the first person? Do you bring this question to your GP? Do you bring it to your ALD expert? Do you bring it to your neurologist? How do we find out who we need to see and what tests need to be done? Do you recommend any testing to tell which type of bladder you are? Do you recommend trying, what are the next steps for someone who's identifying themselves with symptoms and now trying to furiously write down breathing techniques and all of that? But who should people be seeing, and how do you go about that?
Well, depends on where you're located, but if you can come to Kennedy Krieger, obviously you have the team over there, so you're going to have your neurologist, geneticist, your urodynamic specialist. So you ask if there are tests that can be done. Yes, there is this really unpleasant test that women don't mind because most of the women had their legs up in stirrups. Guys don't like it too much. But it does, we fill the bladder with warm normal saline, and we actually see what happens with how the bladder reacts, and if when it starts squeezing, and if it squeezes too much. So that's the physiology or pathophysiology that we can check. According to whatever type of bladder you get, then you might need extra imaging, either ultrasounds or so forth. But if you don't have access to a specialist that looks at neurogenic bladders, a neurourologist is the next best step, or a urogynecologist for women. Now, there are some gynecologists, OBGYNs, that actually know more about the neural part, but you have to ask that question because majority of urologists and gynecologists, really, they look at the normal conditions, not the cabling, and all the neurologic diseases have a problem with cabling. So those are the two next steps. Do not just take a pharmacologic intervention from a general urologist, because they're always going to give you an anticholinergic, because if the urinary incontinence is a very prevalent condition, that's why you have aisles and aisles of adult diapers at the grocery store, because that happens in everyone as we mature and become more intelligent and aware of situations. So the typical treatment is an anticholinergic, which will increase your likelihood of having constipation, which is a consequence of ALD anyway. And there are some studies that show that long-term usage of anticholinergics are associated with cognitive dysfunction. So, we're trying as we age to stay as healthy and as smart as possible. So don't take just the drug because it solves the problem. Figure out what the problem is and then take a drug if that's the case. Then
yes.
you?
So yes, like our multidisciplinary clinic, we start with our physiatrists and neurologists to, address medically, and you should, discuss it with your physical therapist. And if they, are not familiar, they will, move you on to someone else who has more expertise. And so similarly, I think that it's a good place to start the discussion as well.
Excellent. Well, we've got 10 minutes left in this little section, and I want to be very clear. We had no thought that this was going to be 30 minutes to answer every single question, solve it, check done. Thanks so much. This is really intended to be the amuse-bouche of bladder, bowel, and sexual dysfunction questions today, knowing that we are moving into breakout groups where we have an opportunity to really, off camera in some places, and in a greater phenotypic group on the Zoom breakout, but to give people an opportunity to ask questions. But is there anyone or anything coming in on the Zoom? Or I know we had I just want to make sure if anyone wants. Yes, brave people.
Okay, this is going to sound like I have a friend,
Yes.
No, but seriously. No, the reason I say that is because obviously my mother has ALD, but she is in her 80s, so you don't know what's ALD versus what's age. And that's kind of a dilemma with all of us old folks. But the question I have is, you talked all about urgency and constipation, but what about pain? Like I hate to say this, she's got really bad rectal pain. Like, is that something that is just something else completely? And any guidance that you give, because they're now giving her gabapentin, which is giving her no relief whatsoever.
So it's not typically correlated with the neurogenic dysfunction, but as much as having, muscle imbalance, and I'm going to keep it wide, that can create musculoskeletal pain. If it is specific rectal pain, it could be the manifestation of the detrusor sphincter dyssynergia, which is at the rectal level, at the bowel level, manifests as sphincter contractions. And gabapentin is a neuromodulator for neuropathic pain. If it is musculoskeletal, created specific by contraction, by spastic rectal contractions, possibly Botox. It makes for a really smooth, yeah.
I have a long list of questions I would love to ask one of y'all sometime if I get a chance. But my concern, of course, I'm in a small town, and most of my doctors are 1.5 to 2 hours away. That's not a problem. My urologist, the only thing he is concerned about is emptying the bladder. He does not want to listen with the AMN. He doesn't want to listen with anything else. His only thing he wanted to prescribe was Flomax, and that made it worse, especially nighttime. Because when you're asleep and that it relaxes, you've got problems. So I was sitting here looking and to see about a urologist. I'm not even showing one in Little Rock. So is there something I could confront, I can say it that way, my urologist with, just bluntly? Because I know Myrbetriq gets prescribed a lot. And that is my main concern, and I keep telling him the frequency and the have to go right then that's my concern, but he will not look at that.
I'm going to say just ask for urodynamic studies. And those are easier to get. Just urodynamic studies. That's the one with the legs in the stirrup.
Giddy up.
Oh, yeah. I will do anything it takes.
Okay. So it's a sensitive topic, and I thought I would be a little vulnerable here in front of 150 people. So AMN men are struggling with sexual function, obviously because of the chemical and the cabling, and psychosocial factors as well. I mean, already when you have a neurodegenerative disease, you know, you're not feeling very amorous in the evening. You made it through one day unscathed, and you're happy to plop into bed and fall asleep. And so, but I think my message to myself and to fellow men and to partners of men affected with AMN is that we have to redefine intimacy, like we redefine mobility, we redefine professional occupation. And when you look at intimacy, intimacy is made of romance, arousal, desire, pleasure, and fantasy. And there is no reason because men feel like they can't perform, they have an antiquated vision of sexual function. There is no reason to redefine intimacy and romance with the reality of some of our limitations.
Spoken like a true vulnerable female. So thank you for that.
Red mic.
Hello? Hi, I'm asking for a friend. Can we go back, or it could be my mother, it could be me, who knows? But can you describe more the process of the Botox? Like where the needles go, how it's done?
For the
For bladder.
for rectal spasms.
No, for bladder.
For bladder is done by a urologist. It's done during through cystoscopy. So there is a tube that is being inserted inside the bladder. This is all done most of the times under anesthesia if you have sensory function. If you it's not always needed, but yes, it's done under anesthesia. A cystoscope is passed into the bladder. There are about 20 to 30 small injections that are distributed throughout the inside of the bladder. The amount of Botox for the bladder is in between 100 and 300 units. If you get botulinum toxin for spasticity, that needs to be coordinated because you shouldn't be getting Botox willy-nilly. It's an organic compound, so it creates antibodies, and some of them are neutralizing, so diminishes the efficacy. If the question is to the rectal sphincter, that's a smaller procedure. It's just a couple of 25 units or so that are distributed into 4 quadrants in the rectal sphincter.
Lack of feeling below the belt affecting feeling if you are urinating as well as no feeling during intimacy. Have you heard of this?
Can you repeat that? 'Cause
Yes.
I
Lack of feeling when urinating or during intimacy. Have you heard of this?
sensory dysfunction is associated with it, and unfortunately, there is no medical intervention for restoring sensory function. So I'm going to go to the previous very well-informed answer or communication, and yeah, we do not know how to improve sensory function, but cognitively we can solve problems.
I have a question back to Kegels. I know a lot of us know what Kegels are, but I recently heard that one is not supposed to try and stop their urine while they're urinating. Like that's not the time to do Kegels. Is there truth to that?
I would have to look at what the latest literature is on that.
Okay.
I think that is a way to just train the Kegel exercise to occur, but I don't know that you're supposed to do it like every time that you're
No, but-
voiding. Yes.
Someone said that it's not the right time to do it.
Okay. Sorry, I'm not certain.
Take one more. Well, can you just wait so that they can hear?
The New York Times had some great series over the last year on, and there are some gynecologists and I think maybe, God knows, sexual experts writing books, and if you Google it and do the search for Kegels and the muscle we're talking about, I just drew a blank. But they have had quite a few articles, reviews of the book, and then there are people in there that you could Google these people and what they're talking about, and different articles. And yes, they did say you don't do Kegels while you're voiding because that's going to end up perhaps causing UTIs. But there are these other exercises they were talking about too. It's not just Kegels because all the muscles around it too, and then they even have somewhere they have a little video showing a woman doing some of these exercises.
Well, that's definitely something to check out. I want to keep us on time. Thank you so much. Thank you to our panelists. Thank you for the questions and more time to discuss in the breakout.